So we'll discuss histology now, and this is the basic histology of the organs of the GI tract. And in some areas you'll have some modifications, but otherwise these are the 4 layers that you're going to find, and most of what is seen here is what you'll see in all of the other organs. Okay, the epithelium might change. So let's see the 4 layers from within outwards. The innermost layer is what's called mucosa. It has an epithelium, which is the innermost lining, because remember, epithelium lines body cavities or the surface. So this is what is next to the lumen. Next to that is a layer of connective tissue, which is known as lamina propria. And in this connective tissue, in the lamina propria, you can see you may have glands present, you may have lymphoid follicles present. These are known as mucosa-associated lymphoid tissue because this is so close to the lumen. So any pathogens which are present and they enter, you need to kind of take care of them quickly. And then you have a muscle layer which is present here, and this muscle layer is known as muscularis mucosa. In other words, the muscle belonging to mucosa usually has an inner circular and an outer longitudinal layer. And you can see the function of this muscularis mucosa because it's kind of just enclosing this narrow part. When it constricts or relaxes, it kind of causes localized movements in that area. It can also help to squeeze some of the glands, these small glands which are present there. The connective tissue of lamina propria is more or less supportive. It has lots of blood vessels apart from these glands and lymphoid tissue. And then the epithelium, being closest to the lumen, will have a lot of other functions like secretion and absorption. The second layer is here, submucosa, sub meaning below the mucosa. Again, connective tissue, it's loose, it's supportive in function. You have longer and deeper glands present here. You can see these glands in the submucosa. In certain areas of the body, these glands have names and they're very, very large, like the esophagus and, for example, the duodenum. 2 areas very close to the stomach. The stomach produces acid. So anything above or below, very close to it, you need to kind of neutralize the acid. So they have mucus-producing glands in their submucosa. You can see blood vessels present. So you can see these big blood vessels. And you have a nerve plexus which is present here in the submucosa. This is called the submucosal nerve plexus, or also known as, in many parts of the intestine, this is known as the Meissner's plexus. And I think I mentioned this earlier, the way you're going to remember it, S and S submucosa. Okay, so Meissner's plexus. Next to that, the next outer layer, these two are it's called muscularis externa, because now this is on the outside. This muscularis mucosa is also known as muscularis interna sometimes. So this one is called muscularis externa with an inner circular and an outer longitudinal layer. So the circular constricts and the longitudinal kind of sort of goes over the constriction, and both together help in peristalsis. And then outside, the outermost layer is connective tissue if there is no peritoneal covering, in which case it is known as adventitia. So adventitia is when there is no peritoneum in that area. And when there is peritoneum, that is known as serosa. So when there is peritoneum, that's called serosa because it's a thin layer then. Now, in the muscularis externa, which is this one, you see another nerve plexus which is present here. This is known as the myenteric nerve plexus. Myenteric nerve plexus. These two, the myenteric and the Meissner's, we talked of it earlier. These are what are called the gut brain, the intrinsic nerve plexus, which are responsible for contraction of the smooth muscle here as well as the smooth muscle here, plus contraction of the glands. And in this plexus, it has input from the parasympathetic and sympathetic nerves as well, with parasympathetic stimulating it and sympathetic inhibiting it. Okay. In sometimes, you will find sometimes children are born with a part of this nerve plexus being absent. So the myenteric nerve plexus might be absent. And such a disease is known as Hirschsprung's disease. And in these children, you can imagine, and usually the myenteric plexus is absent in the distal colon or in the rectum, so in the lower parts. So what happens is peristalsis goes up to that area, and after that peristalsis can't happen. So the colon, the part above the rectum and the distal colon, gets dilated. And, so you can imagine, so peristalsis, so if this is the rectum and the anal canal, and say there's no plexus here, so peristalsis will come from above, but once it reaches this point, no peristalsis, so all the feces tends to collect here, and these children get constipated because they can't pass it further down. So you usually have to do some surgery and remove that part which does not have the nerve plexus and rejoin the two ends. So let's see this. What do you think is the function of mucosa? Or which of these would not include the function of the mucosa? Oh, okay. The fourth one, that's the correct answer. Generalized bulk movements of the entire organ are not possible by the mucosa. It does cause absorption. Remember, here, it is the one which is closest to the lumen, up here. So when food is digested over here and broken down into its smaller particles, it has to be absorbed in order to get to the bloodstream. It has to go from here pass through that into the bloodstream here. From there, it will reach the bloodstream here. So absorption is a major function. The generalized bulk movements are a feature of muscularis externa on the outside. That's what causes the bulk, the whole organ to move, like peristalsis. Local movements are still possible. This is over here, very, very slight movements, okay? So generalized bulk movements of the entire organ is not a feature of the mucosa. Everything else is. All of these are true of the submucosa except yes, it's not responsible for peristalsis. Remember, muscle. Peristalsis is a movement. It's muscle which is going to do that. It does have glands. It may contain glands, not always. It may have glands, and the glands will pour their secretions into the lumen. After all, that's where you want the secretions to go. Submucosa does contain the Meissner's nerve plexus. And again, look at this slide here. So you see this Meissner's nerve, the spelling is wrong here. Meissner's nerve plexus has glands and blood vessels, and see these glands you can see this duct going all the way into the lumen. So it has to pour its secretions into the lumen, otherwise where else would it go, okay? Now let's say there's an obstruction in the small intestine and a surgeon which he has to remove. Now, which is the first layer he would incise? So he's opened up the abdominal cavity, seen the intestines, thinks there's an obstruction there. Which is the first layer he would have to cut in order to get in to remove that obstruction? The serosa, yes, the outermost layer, okay? The outermost layer, that's what he's going to incise. So you must know the order of these layers. Let's look at the histology of the pancreas and the salivary glands. Now, there are 3 salivary glands, and a very typical feature of a salivary gland is to have, when you, in ANP1, you must have done glands. Glands usually have a long duct like this, which is shown here, and then they have a dilated end, which is maybe flask-shaped or round or anything. The part which is flask-shaped or round, this area is known as the acinus, and this part is the duct. The acinus is the secretory portion, and the duct is the part that conducts it. So here, these large structures which you're seeing are ducts, so they usually have very low cuboidal epithelium. If they are very large, they may have stratified cuboidal, but very big lumen because they're only conducting the secretions. the acini which are present, they, in the salivary glands, they either secrete mucus or they secrete a thin serous fluid. Mucus is very thick. So based on what their secretions are, they stain differently with the dyes that we use for staining. The serous acinus is very darkly stained because it has a lot of rough endoplasmic reticulum in it, so it takes up the stain quite dark. So you can see these are the serous acini. All of these are serous acini, very, very darkly staining. And in the gland, just like if you remember when we did thymus and we did even, which was the others, thymus comes to mind. You know, you saw how connective tissue went in and divided the structure into little lobules. Similarly here, you'll have a lot of connective tissue dividing it into small pockets, and inside many of these lobules or pockets, we have these acini. The darkly stained ones are called serous acinus, and this is what it looks like. So if you look at a typical acinus, it will be like this. The cells are very tall and the nucleus may be rounded or flat, and this is the lumen. So that's what an acinus looks like. So here you can see very, very, acini is plural, so very darkly staining. The mucus acini, which are these lightly staining ones, they don't take up the stain well because the mucus gets removed when we dehydrate the tissue. The alcohol removes it. So they look a little bit like fat cells. These are fat cells, but here you can see the mucus acini, very light staining. You can only see the nuclei. They almost have a frothy appearance. So that's a typical feature of a salivary gland. Now we have three salivary glands. The parotid gland is what is called a serous salivary gland. So it will have only these dark staining acini. The submandibular gland, submandibular salivary gland, is a mixed type of salivary gland. That means it has both serous and mucus, and this is an example of a submandibular. It has both serous and mucus acini. The sublingual salivary gland is a purely mucus salivary gland. So it will only have acini which look like this, light staining. Okay? So that's the difference between them. Now the pancreas, you did the pancreas when we were doing endocrine system. So you saw these islets of Langerhans. So you have these little islands present within the tissue where you can see these cells, and they are the endocrine part of it. Otherwise, the gland looks very similar to the parotid gland. So if you took away these islets, it would be very difficult to differentiate between the pancreas and the salivary glands. So the presence of islets tells you that it's the pancreas. The absence tells you it's the parotid, because it also has serous acini. The exocrine portion of the pancreas has serous acini. You can see all these darkly staining, lots of ducts. You have a few blood vessels also. You may have a little more blood vessels in the pancreas than in the salivary gland because it's an endocrine gland. So naturally you expect to find more blood vessels in it. Okay. So you usually have to, in the lab, differentiate between the parotid and the pancreas, and the way you can differentiate is by the presence of these islets. Let's look at the liver. So in the liver, the cells of the liver are, and if you remember, even before I go to the cells of the liver, if you remember when we were doing the circulatory system, we said that all the blood from the gastrointestinal tract first went into the liver through something called the hepatic portal vein. Can you see that? And this portal vein goes into the liver, and what it does is it breaks up into many branches. And then those branches will finally join. So when it breaks up into those branches give off their nutrients to the cells of the liver called hepatocytes. And then many of those branches will join, and then they finally go into something known as the hepatic vein, and the hepatic vein then drains into the inferior vena cava, which goes into the right atrium. So that's how the blood goes to the liver, gets out of the liver, and finally goes to the heart. Okay? So using that knowledge, let's see what the liver has. So histologically, if you look at the liver, it consists of lobules which are kind of six-sided or hexagonal lobules. And the center of each lobule is a vein which is called the central vein. You can see here, this is the central vein. and this is the hexagon. So you can see many of these lobules over here. So here is the central vein, okay, and here is the six-sided figure. So at the corners, at all these corners of the of this hexagon, you have certain important structures present, and I'll come to that. Those structures are known as the portal triad. So you can see at each of the corners you have these three structures known as the portal triad. Radiating from the central vein, so this is the central vein, radiating from that you get these little plates of cells which are going towards the edges. These plates of cells are known as hepatocytes. So they radiate from the central vein. And in between these plates of cells, you can see these blue structures present. These blue structures are dilated veins which are known as sinusoids. So these blue structures are dilated veins called sinusoids. Now, one of the functions of the liver is to produce bile. So you can see between the liver cells, so between these hepatocytes, you can see these little green dots present between the hepatocytes, and if you kind of pull them up, they form little channels called bile canaliculi. So the liver cells produce bile, which then pass out through these bile canaliculi, and then we'll see that these bile canaliculi finally join and they drain or they go into a larger channel. So we can say that this is a bile duct, a small bile duct. So you can see this here. So the liver is producing bile, which finally drains through these bile canaliculi, which join and enter into a bile duct. So here, let me come back now to the portal triad and what was the significance of that portal triad. So if you see here, I said that the portal vein was bringing blood back from the gastrointestinal tract, and this was, even though it was deoxygenated, it was very nutrient rich. One of the functions of the liver is to take care of the nutrients, carbohydrate, protein and fat metabolism, store certain vitamins, detoxify substances. So all of that has to be done, right? So you want the blood first to go to the liver so that it can take care of all of it, and then once it's done that, then you send the blood back to the heart. So here is a branch of the portal vein. Here's another branch of the portal vein at that portal triad. Here's another branch. So all these blue are the branches of the portal vein which are present at the portal triad. These portal vein branches, they open into those sinusoids. Can you see this? They are opening into the sinusoids which is present between the liver cells. So when they open into the sinusoids, the liver cells can see the nutrients there and they take in the nutrients. And then the deoxygenated blood just travels further. It goes into the central vein. So you can see from the portal vein, it will go into the sinusoid, into the central vein, through the central vein into interlobular veins, hepatic vein, and then inferior vena cava, and that's how it will get out of the heart. Also present at this portal triad is the bile duct, which I told you what was happening there was bile was going into the bile duct. So this will carry bile out of the liver. Now present with the bile duct and the portal vein, because this was deoxygenated, even though it was nutrient rich, it was deoxygenated. The liver needs an arterial supply. So here is an artery called the hepatic artery. So the hepatic artery also lies in this portal triad, and it also pours its blood into the sinusoids. Okay, so it also pours its blood into the sinusoids. So in the sinusoids, you actually have both venous and arterial blood. And here, if you look at this, this is the histological version as seen under the microscope. So you can see at the corners up here, this is where you're going to see the portal triads. So you can see at the corners up here is where you see the portal triads, and here's the central vein. So you can see here are the portal triads which are present here. Okay, so you must know which structures are present at the portal triads. Now within the sinusoids, because such a lot of substance is going into the sinusoids, you're getting blood going into the sinusoid, but the blood may contain material which needs to be taken care of. Inside the sinusoids, I don't know if you can see, but you can see these little stellate-shaped cells which are present in the sinusoids. These are called macrophages, and they're given another name. They're called Kupffer cells, and they're phagocytic in nature. So they phagocytose any cell debris that might be there. This here is another picture just showing you a region of the portal triad. So here you can see these are the sinusoids. Notice this. This is the central vein. This is the portal triad where you have the hepatic artery, branch of portal vein, and you can see bile duct. So notice how the bile is coming from the hepatocytes into the bile duct, and this will be carried out of the liver. The portal vein, its branch is sending blood into the sinusoid, as is the hepatic artery, also sending blood into the sinusoid. So you can see here in the sinusoid the type of blood that is present, and you can also see that the blood is flowing towards the central vein. So first, what does the blood in the sinusoid contain? Yes, it contains arterial and venous blood, not bile. See, you cannot mix bile with blood. Bile is something else. If you mix it, you'll contaminate it. Look at this. The bile is separate. See this? The bile is separate. Here they are together. Okay? Arterial and venous blood are together. See, notice this? Both arterial and venous blood is together. So that the reason why both arterial and venous blood is together, so that the hepatocytes in one go can take nutrition and can take oxygen, and both have to go towards central vein. So why not send them together? You cannot put bile in this because bile is not blood, right? It's something else. It will contaminate it. So you can't have bile in that same channel. So that was the histology of the accessory glands. So let's look now at the rest of the gastrointestinal tract. So in the oral cavity and tongue, so there is nothing much to see here, except that this little picture here, you can see that these are the salivary glands that we talked of. This big gland which is in front of your ear, this part of the ear is known as the tragus of the ear. This area here is called the tragus of the ear. Just in front of this is this big gland called the parotid gland, and its duct passes through and opens into the mouth just opposite the upper second molar tooth, between the gum and the lips. That area is called the vestibule. So it opens into the vestibule of the mouth. Vestibule is the area between the gum and the lip, so opposite the second upper molar tooth. This gland here, just below the mandible, peeps under the mandible, is a submandibular gland, and its duct, the submandibular gland, its duct opens on a little sort of, if you lift your tongue up, you can see a little swelling on the floor of the mouth, so it opens over here. And here, a little higher up in relation to the mandible, this part here is the sublingual gland, and the sublingual has many ducts. And it has many ducts which you can see, all of them, they open into a little sort of raised ridge on the floor of the mouth. So this is where all of your main salivary glands pour their secretions. So you can see they are pouring it into the oral cavity. From there, then we come to the pharynx. So this is the oral cavity. So we've done the pharynx. If you remember, the parts we are concerned with is the oropharynx and the laryngopharynx. So this area, the oropharynx, and this part, the laryngopharynx, after which it becomes the esophagus. So when a person swallows, what happens is the bolus of food will travel down like this. You don't want some of it to go up into the nose, especially if it's fluid. So what happens is this soft palate contracts and it raises it up like this. So it blocks off the nasopharynx from the oropharynx. And when we were doing the respiratory system, you also saw as the bolus fell on the epiglottis, remember, like a lid, it closes over so that it makes sure that the bolus goes down into the esophagus and not into the larynx. Okay? Then once it has crossed the laryngopharynx and it comes into the esophagus, this is a highly muscular tube, about 25 centimeters long. It is present in, most of it is in the thorax, only a very, very small portion in the abdomen. And it has sphincters above and below. Above this sphincter is a circular muscle which is present. So this is called the upper esophageal sphincter. So normally it's kept a little kind of tight. When the bolus of food comes here, it relaxes and allows the bolus of food to travel down. at the lower end of the esophagus, where it opens into the stomach, again, it has to pass through the diaphragm. So this here is the diaphragm. So the esophagus has to pass through the diaphragm in order to enter the abdominal cavity and open into the stomach. So this passage through the diaphragm, one, that opening itself acts like a sphincter, like a valve. But otherwise, at the lower end of the esophagus, there is a sphincter which is called the lower esophageal sphincter, or also called the gastroesophageal sphincter, or also called the cardiac sphincter. This sphincter, usually whenever you have a sphincter, the circular muscle is thick. But this sphincter doesn't have any anatomical thickening. It is what is known as a physiological sphincter. That means it's only on pressure. Usually when no food is present, the two sort of surfaces of the esophagus, the esophageal walls at this end, are against each other. Then as the bolus travels down, because of the pressure being higher over there, it opens the walls and the food will pass down into the stomach, and again it will close. So therefore there is no kind of thickening around there of circular muscle. So it's not what is called an anatomical sphincter. Okay, it's called a physiological sphincter. And as I said, the diaphragm, because it passes through an opening or what is known as a hiatus in the diaphragm. This is called a hiatus in the diaphragm. This hiatus kind of should be narrow so that it only allows the esophagus to pass through. So it also has a pinch cork-like action. The hiatus in the diaphragm has what is called a pinch cork-like action. And it closes it off, and so it prevents any acid from below traveling up, because the stomach produces acid. So it prevents not only the lower esophageal sphincter but even that hiatus. It prevents any gastric reflux or any acid going back into the esophagus, because if it goes into the esophagus, it will erode the esophagus. So sometimes what happens is people may have a sphincter, this lower esophageal sphincter, which is not working properly, it doesn't close properly, and which results in acid going back. So that's known as gastroesophageal reflux disease, or GERD, that's what it's called. Or sometimes that hiatus may be so large, it may not be, it may be sort of too large, so that not only the esophagus but a part of the stomach is going through that opening, and that is known as hiatus hernia. That is called hiatus hernia. And usually hiatus hernia, very often it is implicated in GERD whenever somebody has acid reflux. But sometimes it can be asymptomatic, it's not necessary that they should have that. Another important relationship of the esophagus is with that of the left atrium. So if you're looking at this from the side, the heart lies in front of the esophagus, and the left atrium of the heart is lying directly against the esophagus. In other words, the esophagus lies right behind. So somewhere here is the left atrium of the heart. So sometimes when people have any heart trouble where the left atrium is enlarged, it may compress the esophagus, and the person may come with complain first with some swallowing problems, which is known as dysphagia. So they may complain or swallow. This is just out of general interest, not that I'm going to ask you, but just telling you that, knowing some of these relationships becomes important. So a person may have dysphagia, and you do a study and you look at the esophagus and everything is fine, then you should think that maybe there's a problem with the heart, because the left atrium is related to that. You may be wondering, what are all these numbers which are given? This is, whenever you put a little fiber optic scope, like an esophagoscope, through the mouth and to go into the esophagus to look at it, you kind of have this calibrated. So if it is 18 centimeters from the teeth, from the incisor teeth, then this is where you have reached. When it's 40 centimeters from the incisor teeth, then you have reached the end of the esophagus and you will be in the stomach. So that's what it shows you. So here are some videos to show you what happens in a normal esophagus where the valve is working properly. So notice a normal valve. So I'm going to replay that. So the valve closes and no reflux occurs. And look at the situation where the valve is not closing properly, or there is a So see, the valve has not closed. So can you see that how reflux can go in? And this can also be a situation where you saw in that video, the opening was large, but you could have a portion of the stomach also pass through that, which is known as a hiatus hernia. So this is the process of swallowing. I showed you I told you a little bit. The first, the soft palate closes off the nasopharynx, and then so that food doesn't go into the nasopharynx, and the bolus of food travels down. As it travels down, it closes off the larynx, and then it passes here. So here you can see how the sphincter is closed. When the bolus comes close to it, the pressure increases, that opens the sphincter, and then it comes into the stomach. So let's look at this.
Swallowing occurs in two stages, the oropharyngeal and esophageal stages. Is volume pressed by the tongue up against and backwards towards the pharynx. In response to activated pharyngeal pressure receptors, the swallowing center in the medulla initiates reflexes that prevent entry in passageways. The uvula contracts passages from the pharynx. The laryngeal muscles contract, closing the glottis at the top of the trachea by tightly aligning the vocal folds. The epiglottis down upon the closed glottis. With all left off, respiration is temporarily inhibited. As the upper esophageal sphincter relaxes, pharyngeal contractions drive the bolus into the esophagus. Stage is done and being resumed. During the esophageal stage, primary wave of parasites initiated by the swallowing center pushes the bolus through the esophagus. As the bolus travels through the esophagus, the lower esophageal sphincter relaxes, allowing the food to enter the stomach. If the bolus is sticky in an esophagus, secondary peristaltic weight by the intrinsic plexus at the point of distension, esophageal loop, to finish the swallow.
So he talked about, a phase in the mouth and then a phase which passes into the pharynx and comes. Pharynx is made up of skeletal muscle, as is the esophagus is mixed. The upper third of the esophagus is totally skeletal, the middle is mixed, and the lower third of the esophagus is smooth muscle. And after that, you have smooth muscle everywhere in the gastrointestinal tract. So in the pharynx, it is skeletal muscle, but even though it is skeletal, it is really not under your control. Because you can understand that, when you are, as it said over there, when you are swallowing and the larynx is closed off, breathing is stopped. But if pharyngeal muscles were under your control, you could kind of hold the food in your mouth or in your pharynx for as long as you wanted. And what would happen? Breathing would be stopped for a really, really long time. You don't want it to happen. And this is another reason why they also tell you don't talk when you're eating something, because the larynx is closed. So when you talk, what happens? The larynx opens up and food can go into the larynx, okay? So that's why only the first phase of swallowing is under voluntary control. So when it's in your kind of oral cavity, you can kind of throw it out or spit it out. But once it goes into the pharynx, it's very difficult to kind of regurgitate because it'll quickly go down since breathing has stopped for some time. So let's look at the histology of the esophagus. So it has the same 4 layers. Because it is exposed to food of different texture, of different temperature, the epithelium has to be thick. So the epithelium is stratified squamous, non-keratinized, which you can see here. And the moment it reaches the stomach, it abruptly changes to columnar. So there's no gradual transition. It abruptly becomes columnar epithelium. In the lower third of the esophagus, you see a lot of mucus glands because it's very close to the stomach. So should any acid come in there, that mucus is supposed to neutralize the acid. And as I said, the muscle layer is the muscularis externa, skeletal in the upper third, smooth in the lower third, and mixed in between. So that's the feature of the esophagus. Then we come to the stomach. So this is an organ of varied shape. People will tell you it's J-shaped and it's C-shaped and all. It's a varied shaped organ, can stretch to a great degree because it has, it's very muscular. Plus it has these folds you can see of the mucous membrane. These folds are known as rugae or rugae. and these are temporary folds. So that allows, when the stomach is distended, these folds kind of disappear. But the presence of these folds allows the stomach to sort of expand. It has two openings, an upper and a lower opening. The upper opening is known as the cardiac. So this area is called the cardiac opening, or also known as the esophageal opening or gastroesophageal opening. And the lower opening, where it connects with the duodenum, is known as the pyloric opening. So there are two openings. Two curvatures. You can see a smaller curvature, which is called the lesser curvature, and a larger curvature, which is called the greater curvature. And then the parts of the stomach, this part just below this gastroesophageal or cardiac opening, this area is known as the cardia. This part here is called the cardia. And you can see like the stomach has a little notch like this. So if you take a line from this cardiac notch, as it's called, and go across, the part above is known as the fundus. So it's the highest part of the stomach, usually has gas present in this area. Then the rest of the stomach is called the body. So this big part is called the body, which leads into a funnel-shaped area which is known as the pylorus. This part, which consists of a dilated part called the pyloric antrum, and then that leads into a little canal called the pyloric canal, which stops at a sphincter. This is a true anatomical sphincter. You can see the increased circular muscle over here. So this is a true anatomical sphincter, and this is known as the pyloric sphincter. And you have this sphincter. Remember, you had these sphincters wherever one part went into the other. So where the esophagus went in here, we had the gastroesophageal. Only thing was it was physiological. Here is pyloric, because stomach is going into the small intestine, the duodenum. It has three muscle layers. See, in the muscularis externa, we talked of circular and longitudinal, with longitudinal being outside, circular inside. The muscle has to kind of contract and squeeze and break up the food and, do a lot of mechanical digestion. So you need more muscle in it. So we have an additional third layer called the oblique layer, which is the innermost layer. So you can see this is the innermost layer. So the third layer which is present. And the main function of the stomach is actually not digestion of protein. So there are many cells in the stomach, but the main function is production of something known as intrinsic factor, which is needed for vitamin B12 absorption. And B12, why is that important? B12 is needed for maturation of red blood cells. Now I mentioned that hiatus hernia, so let's look at hiatus hernia here.
This animation will show how a hiatus hernia forms. This animation focuses on the more common type, a sliding hiatus hernia. Click the navigation arrows below the animation screen. Fast forward the animation. Your esophagus, the pipe that goes from your mouth to your stomach, passes into your stomach through a hole or hiatus in your diaphragm. Normally, the stomach is situated completely below the diaphragm, as shown here. The esophageal sphincter acts like a one-way valve to stop the acid that's produced in your stomach to break down food from flowing up into your esophagus. Here we show the valve opening and closing. In a sliding hiatus hernia, the sphincter and the top part of the stomach push upwards into the chest. A hiatus hernia can prevent the esophageal sphincter from closing properly. If this happens, acid from the stomach can pass into the esophagus and cause discomfort, known as heartburn. However, often hiatus hernias don't cause any symptoms. Sliding hiatus hernias are usually quite small. They can slide back and forth through the hiatus, so symptoms can come and go. Sometimes sliding and rolling hiatus hernias are present at the same time. This is known as a mixed hernia. This is the end of the animation.
So here you saw how, acid could go up into the esophagus and damage it, erode it. So let's look at the histology of the stomach. So again, 4 layers, typical, but there are different cells and you should know what is the function of these cells. So first is when you look at the surface epithelium of the stomach, you will find that it kind of dips in to form glands. You can see it's kind of going in like this, invaginating. So where it's dipping in, that part is called the gastric pit. So this is called the pit, and then the lower end is called the gland. And here you have the surface epithelium the cells are mucus cells. And in the region of where the pit becomes the gland, you have these cells are called mucus neck cells because they produce a great quantity of mucus, so that protects the stomach because it's going to produce acid. So you need something to protect the stomach from the acid it is producing. So this mucus forms a nice barrier so that the stomach doesn't digest itself. Then we have very, very large cells called parietal cells, and these parietal cells are the ones which produce HCl and intrinsic factor. Hydrochloric acid is needed because you need the medium in the stomach to be acidic, so that the next cells, which are called chief cells, which produce an enzyme called pepsinogen. This is a protein digesting enzyme. This pepsinogen gets converted into pepsin. It becomes pepsin, and for it to become pepsin or become activated to pepsin, it needs HCl. So that's why the stomach produces HCl. And it just so happens that because HCl is there, HCl is also antibacterial. It kind of helps us. And then right at the bottom of the gastric pit, you have certain cells which are endocrine cells, the local endocrine cells. So these are known as enteroendocrine cells. And these enteroendocrine cells secrete a variety of hormones, of which gastrin is the most important. In fact, the cells are called G cells. These are also known as G cells. Some of these cells also produce histamine, which is not a hormone. But the G cells produce gastrin, which regulates the secretion and the contraction of the muscle from the stomach. So it kind of make sure that the stomach is able to, or it controls the activity of the stomach, the digestive activity, which is secretion from the glands and muscle contraction. And here you can see the cells kind of shown a little bit more detail. You can see the parietal cell and the chief cell. Parietal cell produces HCl and the chief cells produce pepsinogen, and in the presence of HCl, the pepsinogen gets converted to pepsin. And then there's like a positive feedback. So once pepsin is formed, it further kind of makes pepsinogen keep getting converted into pepsin. Now that mucus barrier that I said is really, really important, because you don't want the stomach, if acid went into the walls of the stomach, you'd have an area which is called an ulcer, where the epithelium is gone. So there is a bacteria which all of us have, but sometimes these bacteria in some people, these bacteria may increase in number, or there may be some other problem. The mucus barrier may not be as good, or people may be on some drugs which are disrupting the mucus barrier. In which case, this bacterium is called Helicobacter pylori. What they do is they disrupt that mucosal barrier and they go between the cells. They can kind of travel between the cells and they erode the cells. And so when the cells are eroded, imagine this cell is gone. So then this part is exposed and you get what is known as gastric ulcer. And gastric ulcers, previously they used to think it was because of too much HCl or the mucus was not enough. But now they know that Helicobacter pylori, most of the times, that is the one that is to blame in such a situation. Let's look a little bit at the histology of the stomach.
Upon closer examination of the stomach, the muscular folds called rugae that make up the stomach lining are clearly visible. The rugae gradually smooth out as the stomach fills, permitting stomach distension. Sections that in the openings of the gastric. The gastric glands are different types that contribute various components to gastric juice. Chief cells and parietal cells make up the gastric gland. Pepsinogen is secreted by the chief cells, and the parietal cells secrete it. Hydrochloric pepsinogen into pepsin. Pepsin is a component to gastric juice, is a potent digestive enzyme. By protein even digestion of meats.
So you can digest. We went over this, that it was the lower end of the esophagus and duodenum. I just told you that, so I won't kind of ask you this. Okay, the parietal cell produces HCl, an intrinsic factor, which is needed for B12, and B12 is needed for maturation of red blood cells. What would happen if intrinsic factor is deficient? Anemia, yes. See, intrinsic factor is, vitamin B12 is responsible for maturation of red blood cells. So if intrinsic factor is less, then you won't have you won't absorb B12. Your red blood cells will not mature. And you will get a type of anemia which is known as pernicious anemia. And in such people, it's very treatable. What all you do is you inject vitamin B12 into their muscle, and from there it gets absorbed into their bloodstream. So they don't take it through the digestive tract. So that's what happens. Let's look at the small intestine. It's made up of 3 parts. A C-shaped duodenum, which actually the duodenum itself is made up of 4 parts. There's the first part of the duodenum. This one here is the second part of the duodenum. Then we have a third part of the duodenum, and then this part here is the 4th part of the duodenum. So there are like 4 parts to the duodenum. And the duodenum is retroperitoneal. And then we have this very, very large convoluted tube, which is the rest of the small intestine, which is peritoneal, which is completely covered by peritoneum, has this mesentery, which you can see, which makes it extremely mobile. So the proximal 2/5 is called the jejunum, and the distal 3/5 is known as the ileum. And then the ileum joins the large intestine and it opens into the cecum. So ileum empties into the cecum. The point where it empties, that area is known as the ileocecal valve. So this part here is the ileocecal valve. So this area here, ileocecal valve. So again, you can see when one part goes into another, you get a sphincter at that point. The small intestine is called small intestine because its width is much less than the large intestine. The large intestine is shorter than the small intestine, but it's of a longer width. I'm sorry, what did I say? The large intestine is shorter than the small intestine, but it's of a larger width. Yes. So let's see some features of the duodenum. It's retroperitoneal. As you can see, it's made up of 4 parts, as I told you. It has 1, 2, 3, and this is the 4th part. It has the openings of the the rest of the accessory organs of digestion. Remember, they were the salivary glands, and then we had the pancreas and the gallbladder and the liver. Now, the salivary glands opened in the mouth, but the pancreas and the liver, their ducts open into the duodenum, and you can see here, this is the bile duct, and this here is the pancreatic duct. The two together join, and they open into a little space which is called an ampulla is a dilated space. So they open into a dilated space called hepatopancreatic ampulla, or this part is also known as ampulla of Vater. And then that hepatopancreatic ampulla, you can see, opens into a little projection in the duodenum. If you look here, this projection is the major duodenal papilla. So right here, you can see this. So both these ducts are opening into the second part of the duodenum at this major duodenal papilla. And where they open, again, you need a sphincter to guard it. So that area is guarded by a sphincter. You can see it's called the hepatopancreatic sphincter, or also known as the sphincter of Oddi. So this thing is guarded by the sphincter of Oddi. It's also called the sphincter of Oddi. And here you can see that the pancreas, the head of the pancreas, is lying in the C of the duodenum. And notice here the bile duct and the main pancreatic duct. Sometimes people might have a smaller pancreatic duct, which is called the accessory pancreatic duct, and that opens a little bit higher. And if it is present, you'll have a little projection there, which is known as the minor duodenal papilla. So just in case some of you had a question, what happens to this, what is this other duct doing here? So that was just that if it is present, that's where it will open. So let's look at the special features of the small intestine. So one is, and if you looked again at the previous picture here, if you look at the duodenum, can you see its wall is thrown into little folds? Just as the stomach had these folds, the small intestine also has these folds, and these folds run all along the wall like this. So if you open it up, you can see them. These are known as circular folds or plicae circularis. But unlike the stomach, these are permanent folds. So they do not iron out. When the intestine distends, they don't iron out. So they are circular folds. Then inside the duodenum, so this is what you can see with your naked eye. So these plicae circularis is what you can see with the naked eye. And then microscopically, it has all those 4 layers. But because the small intestine is a place where a lot of digestion and absorption is occurring, so you need to increase the surface area as much as you can. So the first way it increases the surface area is through this plicae circularis, making it folded. The second is microscopically, the surface epithelium throws up evaginations. Invagination means to go in, evagination means to go out. So you can evagination. So you can see it is throwing out these these little projections like this. These projections are known as villi. So this is a villus. And then each cell on the villus, if you look at each cell on the villus, each cell is also the outline of the cell, the surface of the cell is also kind of folded, and that is a microvillus, which is also known as a brush border. So it has increased it by plicae circularis, increased it by throwing out projections, which are villi. Then it has microvilli. Each cell is further folded. The plasma membrane is further folded, and that fold, when you look under the microscope, looks like a little fuzzy brush, so we call it the brush border. And then you notice it also, what it does is the epithelium also throws in invaginations, which form little glands. These are known as intestinal crypts, or what are known as crypts of Lieberkühn, after the person who discovered it. So that's a fourth way that surface area is increased. Plicae, villus, brush border, and these crypts or glands. Some special features of the intestinal crypts: it has a lot of goblet cells. It has special enteroendocrine cells like the stomach. So here also you have enteroendocrine cells, and these cells produce hormones like cholecystokinin. Then you have another hormone which is called secretin. It also produces intestinal gastrin. So these are some hormones which are produced by these cells. Inside, in some of these cells inside which have not been labeled, so I'm just going to kind of put a thing here. These cells are known as Paneth cells. So you have some special cells inside called Paneth cells, which are antibacterial or antimicrobial. So they secrete substances which are antibacterial. So again, they protect the intestine. Lots of goblet cells, lots of mucus produced in the small intestine to neutralize the acid which is coming from the stomach. And then in the duodenum, only in the duodenum, there's a special extra gland present, which is present in the submucosa. And those glands are called duodenal glands, or also known as Brunner's glands. So these are, again, mucus-producing glands. Just like, if you remember, I said there were mucus glands in the esophagus, which is close to the stomach. Similarly, in the duodenum also, you'll have these mucus glands very close to the stomach so that it can neutralize the acid. You want anything to help and protect the intestinal mucosa and to neutralize the acid which is coming. So let's see. The cells which line the villus and the crypts, what do they do? Yes, all of the above. Very good. Now let's look at the liver, the gallbladder, and the bile duct. So these three together, the liver, gallbladder, and bile duct, are together called the hepatobiliary apparatus. And then the pancreas is the other accessory organ. So if you look at the liver, it's a huge, the largest organ, very, very big. It is divided into two lobes by a fold of peritoneum. The peritoneum attaches here at this point here, and that peritoneal fold is called the falciform ligament. And it divides the liver into a left and a right lobe. It has a lot of functions, the liver. It is a major, it produces bile, detoxifies a lot of substances, responsible for carbohydrate, protein, fat metabolism. It produces proteins for coagulation. Remember, the clotting factors are produced in the liver. Thrombopoietin is produced in the liver. So a lot of functions. And a bile production is one of its main functions. So when it produces bile, you saw at the portal triad, those bile ducts were formed. Those bile ducts join, and finally you get the product. They finally end up forming two main ducts, which are called the right and left hepatic ducts. So here's the right hepatic duct and here's the left hepatic duct, which is formed by all those little bile ducts at the portal triad. The two hepatic ducts join to form a common hepatic duct. So bile comes from the liver. So it's coming from the liver, it's going down these hepatic ducts, goes to the common hepatic duct, and then through a duct it goes into the gallbladder. So this duct which is present is known as the cystic duct. The duct of the gallbladder is called the cystic duct. So why does bile go into the gallbladder? Because it goes and the gallbladder stores the bile and it concentrates it. It concentrates it about 50 times. Then when the food gets into the duodenum and bile is needed, then the gallbladder contracts and now bile comes back out of from here, travels back, so through the cystic duct, and where the cystic duct and the hepatic duct join, that part is known as the bile duct. So this area here is called the bile duct. The bile duct, as I said, travels all the way down. It passes through the pancreas. It joins up with the duct of the pancreas, and together, remember, they open at that hepatopancreatic ampulla, which in turn opens at the major duodenal papilla, and that is the part which is guarded by the sphincter of Oddi. Okay? So this is how the bile comes in. The gallbladder, you saw, as I mentioned, it's kind of a balloon or flask-shaped organ. Again, it's very highly folded. This part which is dilated is called the fundus of the gallbladder. And then this bent part is known as the neck, this area here, and then it gives off the cystic duct which joins the hepatic duct. And then the hepatic and cystic will form the bile duct. When you look at the pancreas, it has a head, a body, and the tail, and it also has this little process here which is known as the uncinate process. So this little process here is called the uncinate process. And remember, the tail of the pancreas is the place where you have the most islets of Langerhans. So this is kind of the gross anatomy of these structures. So here is the duct system. So this is, just reviewing it, shows it quite well. Two hepatic ducts form the common hepatic duct, which joins the cystic duct to form the bile duct. The bile duct travels down, joins the pancreatic duct, and then they open into the hepatopancreatic ampulla, which is guarded by that sphincter of Oddi, and it opens into the major duodenal papilla. So here are some of the functions of the liver and the gallbladder and the pancreas. I mentioned that about the liver and the gallbladder. The pancreas has an endocrine function, exocrine. It secretes a lot of enzymes which digest all three food groups, proteins, carbohydrates, and fats. And it also produces a lot of bicarbonate to neutralize the acid from the stomach. Now, let's look at this question. During a splenectomy, remember, last time we saw that the pancreas was very close to the tail of the tail of the pancreas is very close to the spleen. So if you removed it, what do you think would happen? Yes, you would have a condition very similar to diabetes because you're going to remove the islets of Langerhans. The digestion would still continue. In fact, it would keep pouring out of the cut end of the pancreas, okay? But if you remove that tail, the islets are removed, so diabetes would be produced. So that's one thing you have to worry about. So here is the large intestine, which begins from the appendix. So this is the appendix, is the first part. Then this area is called the cecum, and here you can see the ileocecal valve. Cecum goes up into ascending colon, and where it turns, this is called hepatic flexure because it's close to the liver. This is the transverse colon. Where this turns, this is called the splenic flexure. This comes down into descending colon. Then this is the sigmoid colon, the rectum and anal canal. Of these, the cecum, the ascending colon, these are retroperitoneal. The descending colon is also retroperitoneal. Whereas the transverse colon has a mesentery attached to it. And the sigmoid colon also has a mesentery, which is called sigmoid mesocolon. So they are completely covered by peritoneum. Some of the features of the large intestine are, one is you will find that in the large intestine you see 3 bands of longitudinal muscle. You know, in all the rest of the gastrointestinal tract, the circular and the longitudinal muscle were almost of equal thickness and all around the tissue, all around the organ. Whereas in the large intestine, the longitudinal muscle in the muscularis externa, instead of being of the same thickness all around, it's thick in 3 areas and in between it's very thin. So in 3 areas it forms bands, and those bands are known as tinea coli. So those bands are called tinea coli. I don't seem to, here, tinea coli. So you can see this longitudinal band is called tinea coli. There are 3 of them. And since it is shorter than the length of the large intestine, what it does is it causes the large intestine to pucker up. So when it puckers up, it's kind of got little, can you see these little sacculations present? It kind of little sacs. These sacculations are known as haustra or haustrum, or also known as sacculations. So that is because the tinea is shorter than the length of the large intestine, and so it kind of makes it puckers it up, and these are known as haustra. And then another special feature of the large intestine is it has these little fat pockets attached, and which you can see, these are storage areas of fat, and these fat pockets are called appendices epiploicae, or also known as epiploic appendages. Apart from this ileocecal valve, at the lower end where the anal canal is present, you have 2 sphincters. You have an external anal sphincter, which is voluntary, and you have another one in a little bit above, which is called internal anal sphincter, which is involuntary. So you have 2 sphincters in that region. Now the large intestine, its main function is to absorb water from undigested food. Plus, in the cecal area, it may be in other parts also, but mainly in the cecum, you have bacteria present, and these bacteria are known as intestinal flora. They are symbiotic bacteria. They're very important because what they do is all the undigested carbohydrate which is present in your fiber, they are able to break it down. And in return, they supply us with vitamin K, which is helpful in clotting factors, and vitamin B complex, which is needed for a number of cell processes. Any cell which is dividing rapidly needs B complex. So whenever people are on broad spectrum antibiotics, that means antibiotics which act against a number of bacteria. So these are called broad spectrum antibiotics. What happens is they destroy this intestinal flora. And so, you don't produce B complex, and very often people may end up with little mouth sores, or they may have diarrhea or something like that. And when we talk of probiotics, all what probiotics are doing is actually getting more intestinal flora inside you. So that's one of the important things present in the large intestine. The other thing is that fiber in the diet. A lot is talked now about having fiber in the diet, and the reason is whenever you have fiber in the diet, it adds bulk to your feces. And the large intestine, when it contracts, it pushes the chyme, which is the pasty byproduct of digestion coming out from the stomach, it pushes it all the way up through all of this to pass it out. Now it needs volume to push against. So if your volume of your final feces is very little, then it's going to push against something with less resistance. So what will happen is the contractions are so strong that you will end up with little pockets going out like that, which are known as diverticula. So these pockets are known as diverticula, and when they get inflamed, it's known as diverticulosis. So when you add fiber to your diet, what you do is you add bulk to your feces. So then when the intestine contracts, it's got some volume to contract again. So it prevents this diverticular formation. So it's, and prevents diverticulosis and then diverticulitis. So that's the reason why we need bulk in our diet. So here you're looking at the the lower part. So here you can see the rectum and the anal canal. So this here is the internal anal sphincter, which is involuntary, and then here is the external anal sphincter, which is voluntary. Histologically, it's very similar to the small intestine. The epithelium is similar, lots of goblet cells. The only difference being you don't have any circular folds, you don't have villi, you don't have microvilli, and even the crypts, if at all any, they are very, very shallow, but usually the crypts also disappear in the large intestine. So here is the review of large intestine. Its diameter is larger, but it is shorter in length. These are the various parts of the large intestine. Its function is to reabsorb water, and the bacterial flora produce vitamin B complex and vitamin K. So let's see this. What is the function of the ileocecal valve? The function is to prevent, remember, valves always have a one-way flow. So the function is to prevent material going back into the ileum. It is to allow material to get into the cecum, because you want to go from the ileum to the cecum. Otherwise, if it doesn't, then you can't have food, the undigested food being excreted or pushed out from the body, okay? But you don't want it to go back. So everything is one way. So it allows things to go from ileum to cecum, not the other way around. Okay, well, we did this. They produce vitamin B complex and vitamin K. So I did this. Okay.